paper I'll be discussing is calcium-dependent phospholipase A2 modulates infection-induced diaphragm dysfunction. It was written by Supinski, among others, in the American Journal of Physiology in March 2016. The relevance of this paper is to diaphragm weakness in mechanically ventilated patients. For these patients that are critically ill, the force-generating capacity of the diaphragm drops to 20% of its normal value. This means much more difficulty breathing and also contributes to patient morbidity, so there's an increased likelihood of respiratory failure and death. Research has been done to try to understand why this weakness occurs, but it still isn't clear. Possible factors that cause it are ventilator-induced inactivity, use of systemic corticosteroid therapy, and presence of infection. The factor that this paper focuses on is the presence of infection, and as of now, there is no treatment to prevent or reverse the effects of infection-induced diaphragm weakness. Previous research suggests that cytokines play a role in the development of infection-induced skeletal muscle weakness. Research has also shown that animals that overexpress calpastatin, which is an endogenous calpain inhibitor, have greatly reduced diaphragm weakness. So in this study, the researchers decided to experiment with calpain. Calpain is a calcium-dependent protease that is ubiquitously expressed in mammals. You can see its protein structure on the right. Calcium-dependent phospholipase A2, or CPLA2, which structure you can see on the right, is an enzyme that releases fatty acids from glycerol. It specifically hydrolyzes the bond releasing arachidonic acid and lysophosphatidic acid. It's found in mammalian tissue. So how do calpain and CPLA2 relate? The aim of the researchers' study was to figure out whether CPLA2 activation mediates cytokine-induced calpain activation in isolated skeletal muscle cells and infection-induced diaphragm weakness in mice. So they postulated that cytokine-induced CPLA2 activation is a critical intermediary step required for skeletal muscle calpain activation. More specifically, CPLA2 activation elicits generation of mitochondrial superoxide, and that mitochondrial superoxide in turn triggers calpain activation. To test the pathway that they had postulated, they used C2C12 cells, which is a skeletal muscle cell line, within intact mice. They treated the muscle cells in 3 different groups. The first was a vehicle control. The second was a mix of cytokines, including TNF-alpha, IFN gamma, and IL-1 beta. And the third was a mix of cytokines and AACOF3, which is a CPLA2 inhibitor. In each of these groups, after 24 hours, they assessed cell CPLA2 activity, mitochondrial superoxide generation, calpain activity, and calpastatin activity. The researchers first tested the effect of cytokine administration on C2C12 myotube CPLA2 activity. In figure 1 on the right, phospholipase activity is shown on the y-axis, and the control and treatment groups are shown on the x-axis. They found that the addition of cytokine mix to the C2C12 myocytes evoked a 3-fold increase in cell CPLA2 activity. In figure 1 on the right, you can see this as the increase of the red bar compared to the black bar control. The green bar and the yellow bar show the addition of GW4869, which is a neutral sphingomyelinase inhibitor. Since cytokine effects are mediated through muscle-neutral sphingomyelinase, the inhibitor completely blocks the cytokine pathway, bringing activity back to the level of the control. The researchers next wanted to examine the effect of cytokine administration on C2C12 cell superoxide generation. In figure 2 on the right, mitosox fluorescence, which I'll be explaining, is shown on the y-axis, and the control and treatment groups of cytomix, inhibitor, and superoxide scavengers are shown on the x-axis. Mitosox images are shown to the left. The cells were treated with both mitosox and cytomix. Mitosox is a compound that has an increase in fluorescence in response to reactions with superoxide and other reactive oxygen species. So a mitosox assay and a conatase activity were used to assess C2C12 cell-free radical generation. Treatment with both mitosox and cytomix manifested a large increase in fluorescence when compared to control cells treated with saline and mitosox. You can see this as the red bar in figure 2 compared to the black control bar. They also found that administration of AACOCF3, which is a CPLA2 inhibitor, blocks cytokine-induced increases in mitosox activity. And you can see this with the green and the yellow bars in figure 2. In other words, cytokine-mediated increases in C2C12 cell superoxide generation are downstream of CPLA2 activation. Finally, they administered SS31, which is a mitochondrial superoxide scavenger. This blocked the cytomix-induced increase in fluorescence, which further reinforced their results. The overall results of the paper were that 1. Cytokines activate CPLA2 and calpain in the C2C12 muscle cell line, and CPLA2 inhibition blocks calpain activation in cytokine-treated cells. 2. Administration of a CPLA2 inhibitor preserves diaphragm force, generating capacity, and blocks diaphragm calpain activation. And finally, 3. CPLA2 produces its downstream effects on muscle calpain activation and contractile function by increasing mitochondrial free radical generation. So a couple discussion questions. Number 1, diaphragm strength of infected mechanically ventilated patients is half that of non-infected mechanically ventilated patients. Can you propose a way that infection might be making muscle cells weaker? And number 2, what sort of therapies might be able to treat diaphragm weakness in infected patients?